Nasal polyposis is becoming one of the common condition among ENT OP patient. And for the ENT surgeon, this is a very trivial disease as this can be easily diagnosed by nasal examination including nasal endoscopy, and also management is easy with corticosteroids and surgery. But for the patient, it is a very unpleasant condition because it can interfere with the quality of life. So today I will explain about the nasal polyposis, its etiology, then associated conditions, pathogenesis, the evaluation of patient with nasal polyp, and also the management or the treatment plan. Okay. This nasal polyps was described in ancient Egyptian text, and the treatment with the snare was described by Hippocrates also. That means it was there from ancient times, decades ago. And actually this nasal polyp is a Greek term meaning many-footed. Okay. But it is a misnomer actually, many-footed. And the polyp, what is the definition of polyp? Polyp is defined as a non-neoplastic mass of edematous inflamed nasal or sinus mucosa. So nasal polyps are actually sinonasal polyps. And polyp is defined as a non-neoplastic masses of edematous and inflamed mucosa. This can happen in anywhere. Polyp can occur from anywhere where there is mucosa. And in nasal cavity, it happens from nasal mucosa and also from the sinus mucosa. Chronic inflammatory condition of unknown etiology and causing outgrowth of mucosa into the nasal cavity. But this many-footed is a misnomer because this polyp has got only one stalk. For one polyp, there is only one stalk. Okay. The nasal polyposis usually appear as grape-like masses, multiple masses within the nose, having a body and a stalk. There is another entity, a single polyp in the choana, arising from maxillary sinus and seen in the choana. And again, it is called the antrochoanal polyp. The etiology is unknown and the treatment is surgery. And antrochoanal polyp can be cured by surgery alone. So it is not included under nasal polyposis. And I am quoting from Scott Brown textbook, which is considered to be a standard textbook for otorhinolaryngology. And what I am talking about nasal polyposis is purely on bilateral ethmoid polyp. Okay. So again, the etiology of this is unknown. Etiology of nasal polyposis is unknown, and there are so many theories in evidence-based. So one is allergy. Okay. The second is infection. Infection due to Staph aureus. So Staph aureus, Strep pneumoniae, Bacteroides fagilis and Pseudomonas are found to be associated with the nasal polyposis. Especially the Pseudomonas infection is very commonly associated with the cystic fibrosis, which is an associated condition of nasal polyposis in children. Okay. And other causes are autonomic imbalance or abnormal transepithelial ion transport, mucopolysaccharide abnormality, enzyme abnormalities, and also mechanical obstruction. For example, if there is a deviated nasal septum with an inferior turbinate hypertrophy in the nose, there is higher chance of nasal polyposis occurring in that nose. Okay, so these are the supposed or proposed etiologies of this nasal polyposis. There are some associated conditions seen with the nasal polyposis. The first one is in AFRs, allergic fungal rhinosinusitis. There you can see copious amount of very viscous greenish yellow nasal discharge. Usually it is caused by aspergillus and it is locally, it's not invasive, it is locally seen and it is otherwise called a fungal ball. So it is allergic fungal rhinosinusitis. The change of symptoms, that is usually in nasal polyposis you get an copious amount of watery discharge. If it is seen as a greenish yellow and very viscous viscid secretions in high amount, then think in terms of an allergic fungal rhinosinusitis. Other one is an aspirin triad or acetate salicylic acid triad. What do you see there? There is asthma, then there is aspirin intolerance. Okay. And nasal polyposis along with the nasal polyp. So it becomes an aspirin triad, or it can be an asthma, because one of the etiologies suggested for nasal polyposis is allergic rhinitis, and according to the latest unified airway theory, this allergic rhinitis and asthma is seen as a same manifestation of a single airway. So that is the unified airway theory. So, and another one is a Church-Strauss syndrome. What is that? Fever, asthma, eosinophilic vasculitis and granuloma. So all these are seen in Church-Strauss syndrome. Okay. And another one is cystic fibrosis. The dictum is any child of less than 16 years of age having nasal polyposis should be regarded as cystic fibrosis unless otherwise proved. That is a dictum. So remember that. And immunodeficiency states can occur. And also primary ciliary dyskinesia, otherwise called Cartagener's syndrome. What is that? This Cartagener's syndrome, where there is chronic sinusitis, bronchiectasis and sinusitis inversus associated with the nasal polyposis. And Young syndrome. In Young syndrome, again there is azoospermia, sino-pulmonary disease and also nasal polyps. Young syndrome, nasal polyp, sino-pulmonary disease and also azoospermia. Okay, so azoospermia. So all these are associated conditions with the nasal polyposis. And these are the three things, surface epithelium, epithelial defects and inflammatory cells. They play a major role in the pathogenesis of nasal polyposis. The surface epithelium of the polyp is usually, respiratory epithelium, that is ciliated columnar epithelium with goblet cells, and in some cases, especially in long-standing polyps, we can see the transitional cells and also squamous cells can be seen. Especially if it is too big to come to the vestibule of the nose, in that area you can see the squamous metaplasia other than the respiratory epithelium. And also there are epithelial defects because of the inflammatory cells will come and damage the epithelium. You can see the epithelial defects there, and the increased number of inflammatory cells are also seen. So there is increase in the interstitial fluid pressure and also the obstruct blood flow that will lead to formation of polyp. So, and this polyp will come and obstruct the sinus ostia. That will again lead to stagnation of secretions and infection. So there comes the, I already told about the infective pathogens, agents which causes nasal polyposis. So they will come and cause an infective process there also. Okay, so this is the pathogenesis, and increased number of mast cells which release the histamine, eosinophils and inflammatory cells are seen in sections of this polyp. And though the cause is not known, this polyp usually occur in osteomeatal complex area. What is that? That is the area of the middle turbinate and also the middle meatus, where the openings of maxillary, ethmoid and frontal sinus. So that area is called the osteomeatal complex area, and there is a localization of this nasal polyposis there, though the reason is not known. Okay, what about the clinical presentation? The patient will have a history of allergy, sneezing and also watery rhinorrhea for a long time, and it may or may not be associated with a nasal block. Initially, the nasal block will be very small. If nose, septum, middle turbinate, inferior turbinate. Okay, this is anterior rhinoscopy finding. So initially there will be a very minute edema or edema polypoidal nature of the middle turbinate, and later on this progressive increase in nasal obstruction, and also these watery secretions will become more thick, more viscous, and the patient will also complain of a postnasal drip. And this polyp will increase in size. There can be multiple polyps, there can be bilateral, and there can be a complete obstruction of the nose. Associated with that, what all things can happen? There will be anosmia, loss of smell, and if there is loss of smell, there is chance of loss of taste also. Then there will be snoring, mouth breathing. Then if it is causing so much a problem, what comes here? There comes the orbit, right? So it can go to the orbit, you can push the orbit outwards and lateral. In long-standing cases, it can also present as proptosis, and if it happens from early childhood, there can be hypertelorism. That is, the intercanthal distance will be increased. And because this causes obstruction of the sinus ostia, there is also chance of a recurrent attacks of sinusitis and also foul smell from the nose. So progressive nasal block associated with nasal discharge and also postnasal drip, then foul smell, recurrent attacks of sinusitis, anosmia or hyposmia, loss of smell and also loss of taste, then orbital complications like proptosis, that is outward and downward displacement of the orbit in long-standing cases, and also hypertelorism are the common clinical presentations of nasal polyposis. Under the evaluation, how will you evaluate a case of nasal polyposis? The first thing is clinical symptom. I already explained what are the symptoms of the patient, and if you get the diagnosis is actually very easy. There is a very good history that is suggestive of nasal polyposis. Then confirm it by doing examination. What all examinations you have to do? We can again divide that into essential examinations, strongly consider, and you can also consider doing this. So essential is one is symptom history, second one is anterior rhinoscopy. In anterior rhinoscopy you have to probe that also. The typical appearance is a pale boggy swellings like grape-like multiple swellings. Usually it is bilateral, and on probing you can see that it is arising from the lateral wall, especially from the middle meatus, and there will be multiple in amount and it is insensitive to touch because there is no autonomic innervation is completely lost in nasal polyposis. It will be insensitive to touch. So pale boggy swellings, grape-like morphology, multiple polyps, bilateral, insensitive to touch, and arising from usually arising from the middle meatus. So that will be the typical appearance of rhinoscopy. And nasal endoscopy, you have to do a diagnostic nasal endoscopy using 0 degree or 30 degree rigid endoscopy. In nasal endoscopy, there is a staging of nasal endoscopy which is very useful while doing a serial follow-up, especially after looking for the response to treatment. That was devised by Lund, and actually a modified Lund and Kennedy staging in nasal endoscopy is mainly for chronic rhinosinusitis with polyposis. Lund itself, there is a staging for nasal endoscopy, that is from 0 is for there is no polyp, then 1 the polyp confined to the middle meatus, and 2 it is extending beyond middle turbinate, and extensive polyposis is 3. So nasal endoscopy staging from 0 to 3, especially for follow-up and looking for the response to treatment. So all these are essential investigations, and strongly consider doing a CT scan. That is CT scan of nose and paranasal sinus, and if the disease is very small or it's not so extensive, especially with the nasal endoscopy of 1 or 2, you can go for limited cuts. That is only coronal cuts in CT scan is needed. But if there is an extensive polyposis, a CT scan of nose and paranasal sinus, axial, coronal and sagittal cuts are needed in CT scan. Okay, so that you have limited cuts. That is the coronal CT scan of nose and paranasal sinus for 1 and 2 endoscopy staging, and for 3 you need an axial, coronal and sagittal cuts. And consider doing allergy testing, culture and also biopsy. Especially there can be a coexistent malignancy or an inverted papilloma or any other nasal mass can coexist with polyp. So always go for a biopsy of the nasal mass, and special stains if needed, and sweat or genetic testing are needed if you suspect a cystic fibrosis. And also you can go for pulmonary function test, and then aspirin intolerance, because I already told aspirin intolerance is an associated condition. So aspirin intolerance testing and exclude any other sinister pathologies. So this is the evaluation plan for a nasal polyposis. Regarding management of nasal polyposis, it is essentially a combined modality. In early stages, medicines are enough, and if there is no response to medicine or there is recurrence after surgery, it is always better to go with a combined modality. There is pre-operative medicines, then surgery, and also post-operative medicines. Okay, so the management plan, there is essential pathway, and also think of considering antibiotics if there is symptomatic management. If there is infection, give antibiotics, and also aspirin sensitivity, think of an aspirin desensitization, and also decongestants, both local and systemic. And if there is a very extensive polyposis, the betamethasone drops, betamethasone sodium phosphate drops are very effective to reduce the size of the polyp. Remember, this medical treatment will not remove the polyp, but it will reduce the size of the polyp and increase the quality of life of the patient. Okay, so betamethasone drops are usually given for the first 10 to 14 days. Up to 2 weeks you can start giving the betamethasone drops, and the ideal position is the head down position. The usual tendency is to put the drops like this. Think, if you put the drops like this, it will directly go to the digestive tract and there won't be any effect on that. So the ideal position is either it is your leg, your body, and your nose. Okay, if this is your face, you have to stand like that head down position and then instill the drops from here. Okay, or if you cannot stand in a head down position and there is someone to instill the drops into your nose, you can, if this is your coat, you can lie supine with your head down, so that your helper can put nasal drops into your nose. So supine with head down position and then apply the drops. Don't put the nasal drops in the standing position. And intranasal corticosteroid, there are so many corticosteroid nasal spray, mometasone, peclomethasone, fluticasone. Actually, I explain about the medical treatment and also surgery of surgical procedure of nasal polyp in the next class. So intranasal corticosteroid sprays are usually given for 4 to 6 weeks. Okay, and this sprays are usually, one puff is 50 micron. Intranasal corticosteroid spray, one puff is 50 microns, 50. So the maximum tolerable dose per day is 200 microns. So how many puffs you can take? You can take up to 4 puffs. So 1 puff to both nostril, BD. Start with that and then come to a maintenance dose. Then the higher dose can be given for 4 to 6 weeks. Then if there is a response, continue the intranasal corticosteroid spray and you reassure the patient that there is no much of a systemic side effects with an intranasal corticosteroids, because it is not crossing the blood-brain barrier. Okay. Then if there is no response, then go with the systemic corticosteroids. Either you can give prednisolone or you can give dexamethasone. And dexamethasone of 9-day course. 9-day course of dexamethasone is found to be very effective. That is 12 milligram per day for the first 3 days, then 8 milligram per day for the next 3 days, and then 4 milligram per day for the next 3 days. So 9 days. Okay. So that is systemic corticosteroids. And even after systemic corticosteroids, if it is responding, you can continue with the intranasal corticosteroid spray. If there is no response, even after systemic corticosteroids, do a CT scan and do surgery. And even after surgery, you have to continue the intranasal corticosteroid spray. Ideally, a preoperative course of corticosteroids will reduce bleeding of the polyp and the surgery will be very easy. And Post-operative corticosteroids are to prevent recurrence of the polyp. Okay, so this is the plan of management in nasal polyposis. So to summarize, this nasal polyp is a disease of unknown etiology. There are so many proposed theories and also there are associated conditions. Pathogenesis I already told, and clinical presentation is mostly nasal obstruction and rhinorrhea. And in evaluation, you have to go with the symptoms of the patient, then diagnosing nasal endoscopy and CT scan is very essential. And management is mainly by intranasal or systemic steroids, and if not responding, go for surgery. But after surgery, you have to continue the steroid nasal sprays, and also a regular follow-up is needed. Okay, that is all for today regarding nasal polyposis. Thank you.